Good afternoon, friends, and thanks Dr. Prasad and Dr. Vishal for inviting me for this Kanpur Arthroplasty Society meeting. Can I have the slides, please? So, instability is a problem if you have it during surgery. It's actually a symptom, it's not a diagnosis. Actually, we talk about the instability, it's not a diagnosis of some kind of problem. So, it's usually a surgical failure. If you are operating and you see that this kind of opening on the lateral side is there after putting your trial components in, that means a surgical failure. Surgery has not been done properly. And it needs early intervention because bound to progress. As Dr. Wright said, the god of arthroplasty, if you leave something on table, it's going to progress further. It's not going to reduce with time. It can be after trauma as well. After surgery, the patient got some kind of trauma. It can happen after that as well. And this is every surgeon's nightmare because the patient comes very early to you for a failure. And in the literature, the revisions are almost up to 1/3 revisions are because of instability. And mind that early years, 2 to 5 years failure are usually because of the instability which you left on table, which progressed and led to the failure. It can be global or it can be subtle, like can be just in one plane or all planes. So if you define them, there can be 6 different types which can cause the instability for the patient. It can be just a gap mismatch. It can be a component malposition. It can be your ligament insufficiency, can be medial lateral or extensor mechanism. Component loosening can also cause this kind of problem or a global instability because of some kind of neuromuscular problems. Now, where you should be worried about, if you see all these type of patients in the pre-op, then you should be very, very careful in balancing those knees. Where you need lot of correction surgically, or is there a neuromuscular pathology going on, like some patients got a spine surgery, you just be very careful that there may be some minor muscular weakness which can lead to problem later on. If patient is having hip and foot deformities, like patient having a planovalgus deformity, they are very, very tricky. So they can be leading to a lot of problems later on. Rheumatoid patients, a patient's previous surgery, maybe it's a seprectomy or a high tibial osteotomy, and obese patients. The tissues are usually very lax and the laxity can progress very quickly in post-op period. Now, how to diagnose them? Very subjective symptoms, some kind of catching, giving way, recurrent effusions. And if they're recurrent effusions, if you aspirate them, they're primarily having RBCs rather than having more of the WBCs. Patient can have an vague pain medial lateral side. And if there's a mid-flexion instability, sometimes they have a problem while getting up from sitting position or going upstairs and downstairs. You should get long leg films, and sometimes the tibial rotation as a component malposition can cause the problem instability. As you can see in this patient, the tibia is excessively externally rotated, and that led to the unstable feeling to the patient. Patient while walking, they feel something is giving way. So these requires a revision. Now, global instability in all planes, maybe you have put a smaller insert, you need to change the insert, or maybe neuromuscular, then you have to go to a hinge. Now see the extension instability when the patient is having a varus valgus instability in extension. It can be symmetric or asymmetric. As you can see in this patient, the knee is opening medially throughout the range. So MCL is lax and you have to either move to a CCK type of implant or a hinge type of implant. Now if it's a symmetric instability, then we have to, that extension gap is larger than the flexion gap. Then you have to use the distal augments. And if it's asymmetric, then you have to balance the knee by either doing a reduction osteotomy or release more and then put a thicker poly. Now, as you can see here, that's done by my colleague because we have a team. So he finished this right one and said, it looks fine to me. As you can see in your lateral, the video on your left side, there's a lateral opening. And so I said, no, we cannot leave this on table. If we leave this on table, it's going to progress. So we released more and put a thicker poly, and then the knee is properly balanced on the right side of video in your screen. So you should not leave them on table. That's very, very important. Now flexion stability, the flexion gap is larger than your extension gap. So the knee can dislocate. As you can see here, there's a distraction test. If you do an anterior posterior draw test, the knee is subluxing posteriorly. So the patient will have instability while going downstairs. They will have pain either on the medial lateral side, depending on which side they're putting more pressure. Now treatment is that the posterior condylar offset is very, very important. As you can see here in this X-ray, the posterior condylar offset was not restored That's why the knee is subluxing anteriorly and the deflection instability. You have to revise them, put a proper size femoral component so that posterior offset is maintained. And if there is a excessive slope, as we discussed yesterday during the dinner, so then you have to reduce the slope and put a posterior stabilized component. Now just few cases, as you can see here, that's the old knee which was done before, and now if you see the movement.
And pain is a reality in total knee arthroplasty. It's something we want to avoid, but there are myriad of causes that could lead to it. However, our patients have major expectations. They'd want to do something like this after their operation, and we call it the forgotten knee replacement. So what is the forgotten knee? A patient with no pain, full range of motion, no swelling, and no numbness in the knee. So where are we today? 14% of our patients are dissatisfied. The infection rate is 1.1 to 2.2%. There are medical, social, and legal issues associated with this operation. And even if you feel your patients didn't go in for a revision, remember 30% of those needed one, but they didn't go for it. So what is patient satisfaction? So it is the fulfillment of expectations. Satisfaction with TKR is primarily determined by patients' expectations and not their absolute level of function. So we may think we've got them back to doing everything, but ultimately it is a subjective feeling. So this is an algorithm of 10 questions you should follow in an unhappy patient. Always take an extended history. The type of pain analysis should be done. Do a psychological exploration of your patients, a good clinical examination. There are various infiltration tests available, laboratory tests available, a joint aspiration, radiographic analysis, special imaging techniques, and always do a trial of conservative treatment. So what history before and after a total knee? Previous surgery, complications, etc., any comorbidities that could affect the operation, type of implant used, CRPS, any social, recreational, psychological issues. And if they have pain, since when was the pain? Was it day one? Was it after the first few weeks or much later? So this can give you an indication what could be the cause of the pain. Again, where is the pain? Is it throughout the knee? If it's throughout the knee, it could give an indication that it could be overstuffing or infection. Specific locations like a tibial base plate overhang, cutaneous neuromas, etc. What kind of pain is it? Is it pain at night and rest? So it looks like it's an infection, neurogenic, or overstuffing. If there's a starting pain, always think of loose components. When you weight bear and there's pain, mechanical causes or infection. If there's pain on full extension, anterior impingement, posterior tightness or extension mismatch. Pain on full flexion, posterior impingement, patellar impingement or malrotation. If there's pain on descending stairs, think of a flexion gap instability. Look at associated symptoms like constitutional symptoms, consider infection, systemic diseases like rheumatoid, etc. Extra articular pain, look for low backache, hip pain, radiating pain to the knee, referred pain. If there's disproportional pain, you should always think of CRPS. The causes of pain could be extrinsic or intrinsic. Intrinsic could be mechanical or functional. So you could have a CR knee where gradually the PCL stretches over a period of time, leading to instability and causing pain. You could have an internally rotated femoral component that leads to patellar maltracking and pain. You could have instability in the sagittal plane that could lead to pain. You could have malalignment, varus, valgus, that could lead to component weakening over a period of time or component subsidence over a period of time. So these X-rays help early on, even a CT scanogram, to see how your components are placed. And the age-old PS associated patellar clunk syndrome should be identified. Always put your tibial component in the right position, especially laterally. There shouldn't be overhang because that could lead to popliteus tendon impingement and pain. Your tibial component should not be overtly on the medial side because it could rub against the MCL and cause pain later on. Also, overstuffing. So if you use a larger size, you can see that there's excessive stuffing of the patellofemoral compartment. So be very careful in your sizing. Even your cuts in your patella leave adequate amount of bone, but sometimes if you leave too much bone, you may overstuff. So it's like cutting 15 and 18, leaving 15 or 18 bone on your patella when you do it. Do a psychological analysis. If pain is more than 6 months, you need to be doing this because this patient is not a normal patient anymore. A patient may need counseling. A clinical examination, look for stability, swelling, skin condition, look for selective tenderness at various spots, look at the spine, hip and ankle. Infiltration could be done at specific points. Sympathetic blockades could be used, placebo therapy can be tried. Some laboratory tests help like an ESR, CRP, IL-6, the most sensitive and specific being a combination of CRP and IL-6. Dermatological tests to check for any kind of allergy to various metals. When you do an aspiration, a quick check, infection is a huge topic, but I'll try to do that. Stop your antibiotics for 2 weeks. A gram stain is unreliable. The TLC in your aspirate, if it's more than 2500, it indicates infection possibly with a polymorphonuclear cells greater than 60%. Do at least 3 aspirations and a possible arthroscopic biopsy before considering any revision surgery. Do a standing scanogram radiologically, merchant view, contralateral x-rays, pre-op x-rays, stress x-rays. Fluoroscopy helps to check for instability. Special imaging like your technetium 99 scan, bone scan, indium 111 is very specific and CT scans help. So factors to prevent infection, hypothermia, core temperature less than 2 degrees. I'll just finish. Surgical site antisepsis, what is the best thing to use? Chlorhexidine plus isopropyl is the best thing to clean your legs with. Surgical wound wash, use povidone iodine wash. Suture material, triclosan coated and non-braided sutures are the best. HEPA filter, there is no evidence on this. Space suits, not yet established. Blood transfusion has a higher incidence of infection. And laminar flow, there is no established guideline. So in summary, look beyond the knee. Don't neglect the knee though. Investigate your patient thoroughly. Blood transfusion, surgical site antisepsis, sutures and wash have a definite role in infection prevention. So do a revision only when you're sure what's wrong. Thank you.
Thank you. May I call upon the next speaker, Dr. Pranay Bhushan Pandey.
Yeah.
Really sorry for the delay. I think I was not prepared. I was scheduled to come a little later. So good afternoon, and I'd like to thank Dr. Prasad, the organizing committee and the scientific committee to give me an opportunity again to stand here on this platform. So I'm Pranay from Allahabad, and I'll be talking briefly on few cases on periarticular fractures in knee arthritis, proximal tibia and distal femur. So just a brief pre-op and post-op pictures. First patient is a 72-year-old female who's osteoporotic diabetic, had a history of trivial trauma and presented with pain in the proximal leg. So there was a proximal both bone fracture with a bad knee. And after good amount of counseling, still I could not succeed, and I had to go in for a fixation. Tried to do a sink-in nail so that I might later on do just a primary knee, but still I doubt that. Another patient who's a 64-year-old female, osteoporotic, diabetic, hypertensive, pain in both knees, presented with acute pain in the proximal leg. This was her initial presentation when she was advised on knee replacement, and she presented with a proximal tibia stress fracture, and subsequently was operated and did an extension rod on the tibial side, and shows a post-op X-ray healing in around 22 weeks. A third patient is again a 66-year-old female, osteoporotic, hypothyroid, and she presented with acute exacerbation of pain below the knee and had been advised knee replacement earlier. Now this shows a acute on chronic thing that has been happening on the proximal tibia, and had to go in for a long extension on the tibial side, and again united well. So stress fracture, as we all know, is a partial or complete fracture due to repetitive subthreshold manner of stress which the bone is not able to withstand and is not associated with any violent trauma. So first time it was described by Wilden in 1961, and basically of two types, fatigue fracture and stress fracture. Fatigue fracture where the bone quality is good and the forces are more, and stress fracture where the stress is normal but the bone quality is either poor or porotic on an osteoarthritic knee. So the valgum and the varus shift. It shifts the mechanical axis, causing undue stress and loads the lateral or the medial side of the tibia respectively. So on walking, this causes repetitive stress which compounded with sagittal plane deformity and underlying osteoporosis can lead to a stress fracture. So management is of two types. Many people prefer conservative management, non-weight bearing, plaster immobilization, many other techniques. But as we know, conservative therapy in these fractures have many complications like non-union, pseudoarthrosis, malalignment, and if at all you are lucky, can lead to knee stiffness, which ultimately will have to go in for a knee replacement in such knees. So the main treatment comes out to be surgical. What is the main goal of a surgical treatment is correction of alignment, both in coronal and sagittal plane, and replacement of the arthritic surface with fixation of the fracture, stress fracture in a stable manner. There are different techniques that have been described. One, as a basic one for most of the trauma patient surgeons as well as others, and good for patient also, is internal fixation with plates. And then there is a two-stage technique in which you do an osteotomy for correction of the axis deformity with plate fixation, and then a TKR at a later stage. Or you do a TKR and non-weight bearing under fracture healing, which is not mostly used. Long stem TKR with fracture bridging, and long stem TKR with an intramedullary nailing, and combined long stem TKR with an internal fixation, especially in cases where a rotatory stability and fracture bridging is the main concern. Two-stage is obviously once you do in the fixation and it has a prolonged treatment and the pain due to arthritis is still there and you are not catering the malalignment which persists and it delays the union also, and again you have to go in for a second stage with a longer morbidity. So one stage procedure with a long stems, tibial stem bypassing the fracture site addresses both the issues, and it correcting the arthritis and malalignment as well as an internal splinting of the fracture. Many times you have to put in an external additional augmentation, especially in cases where there is non-union and there is a deformity that needs to be corrected. So the possible complications that we can expect in a single stage is that it can lead to periprosthetic fracture, it can cause stress shielding, and end of stem pain, which is there in the last X-ray that I showed. I am expecting a pain because it was a long stem and a size 10 stem that was used. So in planning, there are certain issues that you have to take care of. One is the stem length. So there are different, there's no definite proof as such what length should be used, but Pai et al. Said that twice of the diameter of the cortical diameter of the tibia should be there below the fracture site. Cemented versus uncemented stem. I saw some cemented stem also just now. So general consensus is you have to keep the base plate cemented. You can keep the proximal part cemented. Stem normally is preferred as uncemented. And one thing is sure, that you cannot have cement around the fracture area, that is there. And time of union is normally calculated when 3 out of the 4 cortices shows union, and it is normally averages between 17 to 24, 25 weeks if it is doing well. After 17 weeks, if there is not, 2 cortices are not showing union, then you should think of some other possibility like a bone marrow injection or something. And rehabilitation, we normally prefer full weight bearing after the surgery, but if there is an augment that is used along with that, an external plate or some other implant, then you can go in for a partial weight bearing also initially. And to the end, I'll have one more case, that is a proximal distal femur case. It's a 69-year-old obese patient, osteoporosis, and a retired professor, diabetic, hypertensive. She had a fall in her washroom 2 years back. Just I'll take 2 minutes fast, I'll go fast now. So she went to a trauma surgeon initially, was operated, fixed. Later on, she came to me with a distal femur swelling, pseudosanguineous discharge was there. I thought of infection first time, infected non-union, but everything came out to be negative. So again, fixation versus replacement. Literature shows both possibilities that are there, but replacement has got relatively more result compared to fixation. And in this case, there was a small sclerotic segment that was there in the distal femur. So this I would not have attempted to fix it. And finally went in for a distal femur replacement. And with good results post-op, walking, ambulating nicely. Thank you.
Thank you. Just speed up fast. I'll ask Dr. Wakankar sir to present the last interesting topic.
Of you. Now, we all know that DARE stands for debridement, antibiotics and implant retention, and my title is When and How I Do My DARE. I'm going to just go through quickly about when to do it, and then I'm going to show you a video. Absolute indication would be a very short history of infection, up to 2 weeks since the onset of symptoms. It can be stretched maybe to 3 weeks, but definitely not beyond that. Patient has high ESR, CRP, it's confirmed, the infection is confirmed by aspiration, and you would send for culture and sensitivities, and you would get the grand staining report quickly. Obviously, it will take time for you to get the antibiotic sensitivity report for the infection. The borderline can be just that you're clinically suspicious, but its culture is negative. And patient is maybe already on antibiotics, but maybe you have put them on antibiotics or somebody else has done it. And I think it's important to appreciate what are the definite contraindications. They have to be chronic infection. This is not a procedure meant for chronic infected total knee arthroplasty. A discharging sinus is a big no-no. Any loose prosthesis on X-ray obviously suggests that it is infective loosening, and that is definitely not to be done. Now this patient was my own patient. I had done the TKR 6 years prior. She was in some other town and she developed sudden onset of pain and swelling, high WBC counts and ESR, CRP. The surgeon, orthopedic surgeon locally did not do any aspiration but did ultrasound. Now I can't imagine an orthopedic surgeon doing an ultrasound to diagnose effusion. I think that is something gross, but the surgeon chose to do ultrasound of the knee which showed effusion. And he started the patient on IV meropenem. That was a note that he sent the patient with to me. About 3 days later, patient was already on antibiotics. That is an X-ray. X-ray does not show anything significant. And basically, I aspirated the knee. It showed pus, and we had to go ahead and do the DARE because it was still about 17, 18 days from the onset of symptoms. It was reaching that stage of borderline. And do it under tourniquet with only elevation, so no exsanguination for this. And as soon as I do my skin incision, I would put in get an 18-gauge needle and aspirate. There is purulent fluid coming through, which will again be sent for the entire battery of culture sensitivity testing. And this is, most of the times you have to do a rectus snip on top for you to get the exposure. And that's purulent blood-tinged fluid that's coming through. Now, obviously, the first step is to do a complete synovectomy. The synovectomy has to be done thorough, and after exposure, you would do the synovectomy starting with the suprapatellar pouch, and you need to have some amount of medial release, soft tissue release from the tibia, because ultimately you are going to change the poly. So I always change my poly in order to get first of all to the underneath the tibial base plate or underneath the poly, as well as to get to the back of the knee and maybe debride whatever is possible there. So here I am exposing the plane between the extensor retinaculum and the capsule, and that entire mass of tissue is excised first medially and then working same way on the lateral side. And this entire, you have to send multiple tissue samples as well for culture. Because one tissue culture is not enough, you need to send at least 3 tissue samples for culture and sensitivity. And you can choose the most inflamed area of the tissue and send that off for culture. So similarly, you would expose, I would expose the lateral gutter as well. This is all that has come from the suprapatellar pouch on the medial side. And then I would do the same thing on the lateral side as well. Similar things comes out. Now I generally don't use this cautery here because ultimately I'm going to send some of this tissue off for culture, and I don't want a charred material to go off for culture that's possibly going to come negative. So again do the same thing in the lateral gutter as well and send it off for culture. Now most of the times with patient having active infection, you would have some degree of soft tissue laxity, as you can see here. Now this original poly was a 12 millimeter poly, and I would have to actually revise this poly to a 14 millimeter. Now it's important to, I always take tissue from the box area and send that off for culture as well, because and you know, obviously take swabs from underneath the poly as well. You know, you get all this tissue underneath the poly, and that is swabbed and sent off as well for culture. The more samples you send out, the better, because you need to really confirm the infection. Bacteriological diagnosis is critical for success of DARE. And this is sent off in the Bactex, you know, the ready-made culture bottles there. And then I would use a pulse lavage and, you know, clear all this off. You know, its pulse lavage is very important. At the same time, mechanical cleansing of the surface of the prosthesis is important, because ultimately it's the biofilm that you're trying to get rid of. And biofilm, you know, some surgeons use even a sterile toothbrush, plastic toothbrush, to actually clean that surface. Here I'm just trying out what my poly size is going to be. From 12 I've shifted to 14. This is, I think, 12 poly. And then I'm going to try my different size poly. I'm trying to put a 14 poly and see how it works. In fact, most of the times you have to go in up by 2 millimeters with the poly thickness, and that gives you better stability, because most of these infected knees have developed some degree of soft tissue laxity. Now then I'll flood the knee with 5%. This is a 10% solution that is there. I have dilute by 50%, so make it 5%. So I flood this knee with 5% betadine solution at this stage, and keep that fluid in by clock for 5 minutes. You know, keep it inside, don't do anything until, you know, this is really a contact time of 5 minutes with the betadine solution. Open, you know, maybe put new drapes on, everybody changes gloves, and get a new poly in. So get that betadine in for 5 minutes. After the 5 minutes are over, I will get that out, and again then I will actually physically scrub the surface of the prosthesis using a betadine swab. You can use even a plastic toothbrush, as I mentioned, or even, you know, just try to clean whatever, you know, biofilm that might be there. Biofilm is not going to be visible to the surface. So that is how it is done. Just last 1 minute of the video. And after again I clean that all out, and then I'll get my final poly in. Yeah, the final poly goes in at this stage. Then I'm going to use stimulant, you know, calcium sulfate beads for local delivery of antibiotics. It's useful to know what the sensitivity has been before, so that you can use specific antibiotics. I'll release my tourniquet, let the antibiotics come in through the, you know, that have been given IV, and I'll use stimulant beads with antibiotics. Now, if you've got a gram-positive, you know, bugs in there, vancomycin is the favored antibiotic that goes in the stimulant beads. They're put in the suprapatellar pouch and on both sides and the gutters, and generally tend to have larger of these beads to go in the suprapatellar pouch. And then we will be closing over these. And that is what the postoperative X-ray would look like with these beads in place. Right, thank you.
Thank you, thanks a lot.